First of all, thank you, Lynn, for that very generous introduction. And of course, a pleasant good morning to everyone. My topic for today is about safe opioid conversion. At the end of the lecture, the participants will be able to define opioid analgesia and opioid conversion. Number two, to enumerate the applications of opioid conversion in pain management. And lastly, convert an opioid to another opioid using the equianalgesic dose and other parameters. Opioids are a class of medication used in the management of and treatment of pain. Opioid analgesia is indicated for the management of pain in patients where an opioid analgesic is appropriate. Opioid therapy should only be considered when the expected benefits for pain management and functions of the patient outweigh the forthcoming risks, and it should be a component of multimodal analgesia. In acute pain, you have to remember that you have to use the lowest effective dose of immediate release opioids for a maximum of 3 days. In this cross-sectional study of more than 10,000 doctors lasting from 2009 to 2017, it was found out that opioid prescription was given to around 21% of patients with new onset of low back pain. Opioids are used with or without non-opioids to treat moderate to severe pain for patients having cancer pain. They are often a necessary part of our pain relief plan for cancer patients. Opioids are the mainstay of pain management in patients with moderate to severe pain. When you plan to use opioids for your patient, you must have knowledge of opioid conversion. And when we think of opioid conversion, what comes to our mind is the math. And of course, when there is math, it seems that doctors shy away from this. But you have to remember that the mathematics that you are required to have are only simple multiplication and addition and division, in addition to the knowledge of the equianalgesic dose. Before we go to the main topic, let us first define some terms. Opioid conversion is based on estimated dose equivalencies. Equianalgesic dose is the dose in steady state providing the same analgesic response, and it is standardized to morphine 10 mg IV. For our first application, we are all familiar with this. This is converting the parenteral dose of opioids to the oral dose of opioids. And this is usually seen in our post-op pain management, wherein we initially give parenteral opioids during the first 24 to 48 hours of the patient after surgery. Then we convert the opioids to oral. It can also be done vice versa, wherein oral opioids is converted to IV opioids. Now, when we are treating pain, we have to consider two types of pain. The first one is the persistent pain. For the persistent pain, we administered our opioids around the clock, or we give it through infusion, or for some medication, it is delivered through continuous way. And the other one that we have to consider is breakthrough pain. This is the pain that breaks through our medication. So our second application is when rescue medication is using a different molecule. Initially, usually we only use one molecule. For example, if we give morphine for our persistent pain, then we also give morphine for our breakthrough pain. But for patients having fentanyl patch, they use another molecule for their breakthrough pain or rescue medication. wherein they can give morphine tablet or other opioids. So this is our second application. Now, for our third application, we have to consider it in the context of chronic opioid therapy. This is where when our expected good results are not seen, like increasing dose without increasing analgesia, or patients do not achieve their goals or improvement even when there is analgesic efficacy of the drug. So in this case, we have to establish a new therapeutic strategy in the administration of opioids. And one of these strategies is what we call opioid switching. So what is opioid switching? It is a process of changing one opioid to another to obtain a satisfactory clinical balance between analgesia and adverse effects. And our fourth application is in the treatment of cancer pain. We are aware that cancer is progressive, and so is the pain that accompanies it. Our patients may need increasing dose, change of route of delivery of the opioids, or may even require a change of opioids from weaker opioid to stronger opioids or to other opioids. Now, what are the challenges in opioid conversion? First, there are weak literatures. So you cannot find one evidence which will contain all the necessary steps in opioid conversion. There is also a lack of a widely recognized treatment algorithm or guideline, and we do not know how to do about the opioid dose. Are we going to increase or decrease? So let me tell you how to do it. First, use of opioid conversion tables solely is an oversimplification of pain management. So you can find the opioid conversion tables in the internet, but that is not adequate for opioid conversion. So recent data has shown that there are factors to consider when you do opioid conversion. These are chronicity of opioid use, total daily dose, ethnicity, age, and direction of conversion. Now let's go to the first step. So first thing to do is determine the total opioid dose or TOD for the previous 24 hours. TOD is the sum of the round-the-clock drug, opioid, and the rescue medication. So let's look into our case. This is a 60-year-old female patient taking sustained release oxycodone. She took 40 milligram per tablet every 12 hours with rescue medication of oxycodone, immediate release 10 milligram per capsule. For the past 24 hours, the patient had taken 4 rescue medication. She had developed intolerable sedation, and she would like to try an immediate release morphine. How do you convert to morphine? So our first step is to take the TOD. The round-the-clock dose is 80 milligram, and the rescue medication is 4 of 10 milligram capsule, making 40 milligram oxycodone. So our TOD is equal to 120 milligram oxycodone. The next step is calculate the equianalgesic dose using an online dosage calculator. But if it is not available, the equianalgesic dose is equal to the TOD multiplied by the conversion ratio for our patient. Now, this is the table for conversion of oral morphine to other opioids. Here we see morphine to oxycodone with a conversion ratio of 1.5:1, meaning that an oral morphine 15 milligram is equal to oral oxycodone 10 milligram. Now, I'd like to show you other conversion table. In this one, oral opioid is converted to its parenteral preparation. And this one is parenteral morphine to other parenteral opioids. Now, going back to our case, remember that our conversion ratio here is morphine 1.5 milligram to oxycodone 1 milligram. And oxycodone to morphine entails that we classify these opioids. So oxycodone is the stronger opioid compared to morphine, and morphine is the weaker opioid compared to oxycodone. In these cases, we multiply oxycodone with the conversion ratio. In another case, wherein morphine will be converted to oxycodone, we again classify the opioids. Now, morphine here is the weaker opioid compared to oxycodone, and again, oxycodone is the stronger opioid compared to morphine. So in this case, we divide. So the equianalgesic dose for our TOD of 120 using the conversion ratio of 1.5:1 is 120 times 1.5 is equivalent to 118 milligrams. So 120 milligrams of oxycodone has an equianalgesic dose of morphine, which is equivalent to 180 milligrams. So here, we multiply the stronger opioid with our conversion ratio. Now, the third step is to consider cross-tolerance. So this will reduce your equianalgesic dose by 25% or 50%. It has been found out that when you use novel drugs or you shifted to a new drug, that the effect will be much greater. So how do we choose which one to select? So if it's closer to 50%, so you have to look into the following characteristics in your patient. High dose of the opioid being discontinued. Patient is elderly, medically frail, not white. It is closer to 25% when switching to a different route of administration of the same opioid. So we choose closer to 50% because our patient is elderly, medically frail, and not white. Now, the equianalgesic dose of oxycodone to morphine is 180 milligrams, and to account for cross-tolerance, we multiply this with 0.5, which is equivalent to 50%, and therefore our dose now of morphine is 90 milligrams. Now, the next step is to consider the frequency. So you have to also know the pharmacology of your drug. So the duration of action of morphine is 3 to 4 hours. So if we choose to give morphine every 4 hours round the clock, then we divide 90 milligrams by 6, and therefore the patient will have 15 milligrams of morphine every 4 hours. Now, as I mentioned a while ago, we have also to consider the breakthrough pain of the patient, and we have to compute for the rescue medication. The rescue medication is around 10% to 1/6 of the total opioid dose. For me, in my practice, I usually use 10% because it's easier to compute without a calculator. But we have to get used into getting the range, particularly for the president. So we compute for 10% of 90 milligrams, which is 9 milligrams, and 1/6, which is 15 milligrams. Now, the fifth step is preparation. So if we have morphine 10 milligram tablet available in our pharmacy, then morphine 10 milligram per tablet will be administered as 1.5 tablet every 4 hours. And the rescue dose, as we computed it, is 9 to 15 milligrams. Therefore, we can choose morphine 10 milligram per tablet since the available preparation is 10 milligrams. Now, the final step is to assess and reassess our patient. Now, where is our patient now? And how many rescue meds in 24 hours, and do we need to titrate? These are the questions that we have to answer. So when we go and check on our patient, we look at the status of the patient. If the patient is in pain, and this we will see with the number of rescue medication, and then we have to titrate upwards. But if we do our rounds and see our patient smiling at us, then we have to maintain the dose. But if the patient is overly sedated, then we have to decrease the dose. Now, the patient is requesting that morphine will be shifted to fentanyl patch so that she will not wake up after midnight to drink it. For the past 24 hours, she had 3 rescue medication. So there is a golden rule in opioid conversion. When changing from one opioid to another, always convert to morphine first. But that will not be our problem because from oxycodone, we already have computed for morphine. Okay, so the steps apply. So we first compute our TOD, which is 120 milligram of morphine. Then look at the conversion ratio wherein fentanyl 1 milligram is equivalent to morphine 100 milligram. Then compute for the cross tolerance. We have 120 milligram. Our patient is an elderly, so we multiply it by 0.5 and 60. So we have here our conversion table from oral morphine to transdermal fentanyl, and we can see that we have the same answer. So now fentanyl milligram is equal to morphine over 100 because fentanyl is a stronger opioid and morphine is the weaker opioid. And we are converting it backward, morphine to fentanyl. So 60 milligrams divided by 100, we get 0.6 milligram. But you know the preparation of our fentanyl is in microgram. So we have to multiply the 0.6 milligram to 1,000 to convert it to microgram. Okay? And then the frequency, since we know that delivery of fentanyl is 24 hours for 3 days, then we divide 600 to 25. And we will now give our patient 25 fentanyl 25 microgram. So after that, we again have to assess and reassess our patient. Do we need to change the rescue medication? So the round-the-clock dose of our patient is morphine 60 milligram per 24 hours, which is equianalgesic to fentanyl patch 25 microgram per hour, making the rescue medication dose of morphine 6 to 10 milligram. Since our preparation is 10 milligram, then we can use morphine 10 milligram per tablet, 1 tablet every 2 hours for pain score of 4 and above. For treating cancer pain, we have to remember that if we titrate our round-the-clock dose higher, then we have to recompute our rescue medication, and it could also be higher. The same thing is true if we titrate downward. We also have to compute our rescue medication dose. So here I would like to show you with regards to buprenorphine and being converted to morphine. So here, buprenorphine 1 milligram IV is equivalent to morphine 75 milligram tablet, and buprenorphine patch 5 microgram per hour, which is equivalent to 120 microgram per day or 0.12 milligram per day. Now, morphine oral, then you have to multiply that by 75, giving us 9 milligram per day. But our current conversion table of 2016 shows that tramadol conversion is 5 or 10. So here I multiply the 9 milligrams by 5 and 10, giving us 45 and 90 milligram per day of tramadol. So here is the transdermal buprenorphine to oral morphine, but the computation is only from buprenorphine to oral morphine. So how can you give 9 milligrams of morphine in 24 hours? If you divide it by 6, it's only 1.5 milligram. So if we use oral tramadol dose, buprenorphine 5 milligram is equivalent to 45 to 120 milligram in 24 hours. And of course, as we increase the dose of buprenorphine, the dose of oral tramadol also increases. So for the 10 milligrams, it is equivalent, equianalgesic to 20 to 90 to 240, and buprenorphine 20 is equianalgesic to 180 to 480 milligram. Okay, all of these conversion factors, conversion ratio of opioids are all recommendation, and you, the anesthesiologist or pain specialist in front of the patient, can adjust the dose based on the clinical response of your patient. So here our learning objectives. So we define opioid analgesia as the use of opioid when appropriate for our patients in pain, meaning that we have to ensure that the benefits of opioid therapy outweigh the risk for our patient. Opioid conversion is converting one opioid to another based on the route, that the classification of opioids. We have enumerated the application of opioids as the first one is changing the route, and then the chronic opioid therapy, and when rescue medication uses another molecule, and for our cancer pain patient. So when you convert an opioid to another opioid, there are 6 steps. The first step is you have to compute for the total opioid dose in 24 hours. And then you calculate the equianalgesic dose by the use of the tables so that you will know the conversion ratio. So if you are converting strong to weaker opioid, you multiply, and vice versa, weaker opioid to stronger opioid, you have to divide. After that, you compute for the cross tolerance. You have to choose from 50% or 25%, depending on the characteristic of your patient. And the fourth, you have to compute for the frequency. And then the fifth, you look for the preparation of the drug. And lastly, of course, you have to assess and reassess your patient. Thank you for your kind attention.